Thank you very much for that kind introduction. And everyone, it's nice to meet all of you here. I've got to meet a few of you so far and hope to meet you during the breaks. This is the first time I'm seeing my slides on the VHC template, so hopefully it'll be fine. Two comments. One is that this is an excellent review. I have to cover our fellows clinic on Wednesday, which is all general GI, so nice review. And unfortunately, I have the pleasure of following an excellent talk with lots of cool videos, so mine does not, but we'll make it through. So a pleasure to speak today about when to refer for liver transplant evaluation. I think this is always a question that comes up for our GI community providers about when's appropriate and why some of the practices we do of this. These are my disclosures. These really have nothing to do with today's talk. So today what I'd like to do is have you guys understand the current deceased donor allocation system in the United States, review historical indications and contraindications for liver transplant, understand some emerging indications for this, and then describe how you, as sort of our community providers, can optimize your patient for liver transplant evaluation before they see us. So we have to start about simply just talking about cirrhosis, right? This is a growing problem in the United States and actually across the world, and we know it exists on a spectrum, right? Our patients start in a compensated state and have a median survival of over 12 years in general, but eventually may develop clinically significant portal hypertension manifest by varices or collaterals when you get cross-sectional imaging, and then eventually have a decompensating event. And that really signals a really significant change in their mortality, where the median survival, at least according to older data, was 1.5 to 2 years, and that's really where we start to think about evaluating for liver transplant. Now, researchers, certainly in Europe, have actually classified cirrhosis into different stages depending on the type of decompensation they have and then further decompensation. But just thinking about it mechanistically, what that really just signals is as we progress over time and then increase portal hypertension and develop these decompensations, there's a shift in mortality, as seen in that kind of upper right figure, with each year, each decompensating event essentially increasing your 1-year mortality rate, and similar counseled by that table. I think when we talk about cirrhosis, we always talk about the MELD score and Child-Pugh score, which are both validated markers of mortality for these patients. And certainly play a large role in transplant selection and eligibility. But really, these only tell us some of the story about a patient's individual mortality. I think we all are very familiar, certainly with our patients with MASLD or MASH, that tend to have lower MELD scores compared to folks with things like hepatitis C or alcohol, and may suffer from actually even more portal hypertension problems, repeat hospitalizations, frailty, all the kind of things that definitely impact quality of life and mortality, but are not well captured by those MELD score and Child-Pugh score. And there's also been well-identified things in the literature, including the presence of hypotension, frailty, and then various endocrinopathies such as acquired adrenal dysfunction. So we're talking about transplant today, and this is just a nice map put out by one of our former AASLD presidents, Nora Turow, 2 years ago, just showing kind of the landscape of transplant actually across the world. I'll say the countries in white, which obviously most people recognize Russia as well as Africa, doesn't mean there's not transplant being there. It's just we don't have good data there. But as you can see in the United States in that dark blue, quite a hotbed. This was from a few years ago, but there's over 25 transplants done per million population. So, I think this, talking about donor allocation, how we actually, give organs out and things could be its own lecture on its own, but I'll just kind of set the stage here. The first transplant was done by Thomas Starzl in 1963, and since that time, obviously, transplant has increased in both popularity as well as surgical technique and, most importantly, outcomes. In 1984, the U.S. Congress established the National Organ Transplantation Act, which set up OPTN, or Organ Procurement and Transplant Network, which sort of governs all of this. And how we actually allocated organs initially was based on the sickest first phenomenon, where basically patients in the ICU that were on a wait list for a while got higher priority. The problem is, you can see that's easy to game the system, right? You list someone really early and then you put them in the ICU and they can get transplant, right? And that's a problem. Over time, we've sort of refined this to kind of better stratify patients, using things like the Child-Pugh score, which again has some subjective characteristics in terms of ascites and encephalopathy. And then in 2002 was the seminal event where we started to use this MELD score to be a little more objective about this. But as we talked about, there are some problems with using the MELD score. And then they've set up these things called DSAs, or donor-specific service areas, which are actually run through centers of Medicaid and Medicare. And actually, the entire U.S., as you can see in this map here, is set up into 11 different regions. We're in region 11. That was meant to kind of roughly divide transplant and organ allocation across the country. But given differences in population and median male transplant, there was inequity across the system. So over time, we've refined the system and come up with improvements. Now, in February of 2020, right, if that rings a bell, that was literally, I mean, a few weeks before COVID hit, OPTN actually rolled out this new allocation system. This is currently what we're using now. And so that is when a potential donor essentially passes away at the hospital. So for example, here at VHC, or at UVA down in Charlottesville, that organ actually goes to what we call an organ procurement network, organization, which there are about 55 across the entire country. And in that area, you have one or more transplant hospitals that may be eligible for that. But how they actually get set up depends on the status of the patient. So our status 1A patients, right, our acute liver failure patients, for example, get access in high priority actually up to 500 nautical miles. That's why that circle is actually based on nautical miles rather than real miles. I don't understand why, but. And then based on that, as you go down the list in different buckets, you get increased access to the organs. So the reason this was changed is really to sort of try to balance this out across different places. Actually, Virginia, we were fortunate under the old system because just from a geography standpoint, we had a large area and less population compared to places like Philadelphia or New York that have a lot of patients and also higher proportion of minority patients, which were felt to be disadvantaged. So that's why they changed this system. We've also incorporated what we call the MELD 3.0 score, which in addition to our bilirubin, INR, and creatinine now includes albumin and female sex as variables, because we know that females, unfortunately, previously were disadvantaged in the system primarily because they have less muscle mass at baseline compared to males, so their serum creatinine would be lower and they would be underrepresented. Probably the most important thing and exciting thing in my field, though, is that there's increasing transplant in general. This is a nice curve at the top here looking at the increase in transplants from 2012 to 2024 from a deceased donor standpoint. You can see it's over tripled and nearly quadrupled over that time, which is great. A lot of this has come from increased use of deceased donor organs, including those from high-risk donors with a history of hepatitis C or hepatitis B, and certainly UVA has been a leader in that. But also we'll be able to use organs from patients that have deceased after cardiac death, right, where you essentially have their heart stop and they lose temporary perfusion to their liver. But we also can use more steatotic grafts, which certainly in the age of mast cell to mash it becomes a bigger issue, as well as older donors. And there's novel techniques that are being used at UVA and other centers, including normothermic regional perfusion, as well as normothermic machine perfusion, or what you may hear of as the pump. And I can tell you, sort of in coming up here last night and then this morning, I've already seen like 3 or 4 emails of organs that are already coming to patients on our wait list already, which is great. So I think many of us are familiar with traditional organ indications for liver transplant, right? These are sort of the ones you learn in, certainly throughout your training. So for most of our patients, it's end-stage liver disease, which is the development of a decompensation and classically a MELD score of at least 15 on a pretty regular basis. And the patients with this tend to, you know, when we think about liver transplant for this, they also have to not have an expected mortality independent of the liver disease, you know, within the last few years, right? So we want that liver transplant to be durable and last a long time and really give them extended life. And of course, we want that transplant to actually improve their quality of life, right? Some patients may have comorbid conditions which may not improve with transplant, which may not, you know, transplant may not ultimately improve their quality of life. Certainly for HCC patients with within Milan criteria, right, which is 1 lesion less than 5 centimeters or up to 3 lesions equal or less than 3 centimeters. Patients with acute liver failure, and then certainly in well-selected patients with hyalocholangiocarcinoma, such as our PSC patients. This figure is taken by, from our ASLD guidelines actually over 10 years ago as contraindications to liver transplant. And I will say this is very outdated at this point, and it's actually being rewritten actively right now. As you can see here, at this point, it talks about a MELD score of less than 15. It also talks about AIDS, which certainly AIDS by itself is, but in patients actually with our HIV positive that are well controlled on medicine with good adherence can be transplanted successfully, and we've done that as well. I think on here, interesting, it says ongoing alcohol and illicit substance use. I think we all are very well aware the alcohol policy has changed over time. We'll have a slide on that later. But alcohol use is really center dependent and risk stratified depending on frequency, kind of social support, other psychosocial factors. I will say, right, a lot of patients may use marijuana or THC products. Usually it's acceptable as long as they does not impair their functionality. But certainly hard drugs like cocaine, methamphetamine, heroin, et cetera, will be contraindications. Patients with a history of extrahepatic malignancy, as long as it's not super recent, may also be candidates, but certainly active malignancy needs to be treated first. And then also, I've circled down here persistent non-compliance or lack of adequate social support. I think these are probably the biggest barriers a lot of patients face, and certainly as the referring providers, they're things that you may be aware of as well, and these are major red flags. I'll also point out certainly a bigger problem here in Virginia is actually just access to reliable transportation, just with geography and a lack of centralized public transportation. This may be a barrier for certain patients as well. So we talked about this MELD score 15 cutoff, right? And so where does that really come from? So this is a nice study published 20 years ago that actually looked at patients that had been transplanted and kind of bucketed them by their relative MELD score. And what you can see over the time, this is a hazard ratio, and it's actually looking at the patients that got transplanted with these various MELD scores, what was their risk of one-year mortality for those that actually got transplanted over those that were still on the wait list. And so you can see actually in the low MELD score below 15, they actually did worse if they got transplanted compared to staying on the wait list, right? Those that were in 15 to 17 range was sort of equivocal, and certainly when their MELD score is 18 or above, they benefited. So this is where that sort of data has come from in the past. So where are we going with liver transplant, right? I think a lot of centers, and certainly UVA is leading this, is sort of these kind of non-traditional indications for liver transplant where we have acceptable survival. And one of my partners, Dr. Zachary Henry, leads a transplant oncology clinic that deals with a lot of these patients. So one of the most common things is HCC outside that Milan criteria, which includes patients with a history of tumor in vein, which classically has been thought of as a metastatic equivalent. But actually with aggressive local regional therapy such as Y90 and immunotherapy, this may regress in some patients, and with stability they actually can be transplanted. And in patients just in general that have received immunotherapy, this is no longer a barrier, and we have good data that's continuing to emerge that these patients can be safely transplanted if they remain stable. Patients with a history of colorectal cancer with or without underlying liver disease, with liver-only mets can be transplanted, patients with neuroendocrine tumors, and then in very well-selected patients with intrahepatic cholangiocarcinoma. I have one of my patients that actually got a transplant with this and is doing quite well now. By this, we mean in general, the data comes from kind of retrospective big cohorts. This is the figures from that. But in general, if it's 2 centimeters or less, they actually have very low rates of recurrence and good long-term survival. So we will consider that. All these, though, of course, are protocol-driven and typically done at large centers. So we talked about, how we're increasing the transplant rate and, and increasing organ utilization. But what can you guys do? I think looks like the title got mistranscribed here, but really what can we do as community providers as we're referring patients to really optimize our patients for transplant? I think it's well worth taking a few minutes in clinic if you have that time, or certainly referring to a dietitian to really talk about nutrition, because that's really where these patients struggle. It's important to emphasize a high protein diet, which usually is about 1.2 to 1.5 grams per kilogram, which is quite a lot. It's usually 100 grams or more of protein a day, and so most patients require supplementation with shakes, various like 30-gram protein shakes out there. And it's really important to think about the physiology of these patients because they are so starved when they go to bed, right? That's a whole night of essentially ongoing catabolism, and so giving them a bedtime snack and actually making sure they eat something when they wake up in the morning will help shorten that process and hopefully kind of slow down the progression of sarcopenia. And the reason we care so much is that sarcopenia and its associated kind of clinical manifestation of frailty really is a poor predictor, certainly of waitlist mortality, and that's certainly a big issue with our MASH and MASL patients. This is a nice data from Jennifer Lai that was published in one of our major journals nearly 10 years ago, where you can see for patients with kind of various MELD scores, whether they're robust or frail, the frailty patients definitely did a lot worse, and so we really try to buff them up previous to this. I also talk to patients a lot about exercise, and I don't mean going running marathons, although occasionally we have patients do that, but really to sort of just walk, swim, even just do light weights while they're watching TV, just to kind of preserve that skeletal muscle mass, because your skeletal muscle is actually really important to metabolize ammonia, so this can actually reduce their HE risk and reduce risk of falls and hospitalizations. PT/OT services definitely are helpful in these patients, and kind of picking out to our bariatric colleagues here, in compensated patients, GLP-1s are usually fine. I will say in severe, especially in our severely decompensated patients, we generally recommend stopping these because the expected benefit is low compared to the risk and further of the sarcopenia. And then certainly if we're ever thinking about putting a TIPS in a patient or treating Hep C in our decompensated patients, it may be worth considering referring them for early transplant evaluation to sort of have as a backup should those interventions not go as planned. I think one of the other things that's important to think about, certainly as transplant hepatologists, but also as our community GI partners, is really, are there patients that are too well for transplant? Are there patients that maybe should come see us early? And this is hard, right? there's this concept out there of what we call recompensation, right? Which is where a patient has had a decompensating event, right? They've had ascites, they had maybe a bleed, but over time they actually get better and that portal hypertension reduces. This is much more common in kind of what we consider reversible etiologies. So if you take away the stimulus that's injuring the liver, right? So they cease alcohol, you treat their hepatitis C, or you knock down their viral load if they're actively hepatitic from it. And in patients that go without a year, can get off medications, these patients actually do fairly well. Not as well as someone who's originally just compensated, but they may not need urgent transplant evaluation and should just continue to be followed. Now, I think a harder question is in the patient that's had a single decompensation, right? They've developed some ascites or they had an episode of HE when they're hospitalized, but currently they're an outpatient, they're doing reasonably well, their MELD score is not that low. I think with close follow-up, these can be followed in the community, but certainly if that MELD score progresses or, they develop worsening of that or become refractory, we certainly would recommend having them be evaluated for transplant. A really difficult population are those with the low MELD score and then just have really poor quality of life, and I think we see that all the time in our clinics. This tends to stratify more in our MASH and MASH patients, but those that just have profound fatigue, malaise, repeat hospitalizations, but we don't see that MELD score grow up. So there's sort of this discrepancy between their perceived need for transplant, which may improve their quality of life long-term and life expectancy versus their access to that organ. We do often recommend seeing these folks. We're more than happy to see these, and I think that's where we talked about and really try to get a living donor for these patients. And then, of course, kind of a growing, just with the aging population, is those patients that are kind of approaching 70 or even older than that, that may be doing okay, but you're worried over the next few years with the natural history of cirrhosis, they'll decompensate, and are they going to ever age out of transplant? And I try to dispel the term. There's no absolute cutoff of age for this. I think certainly once patients get over 70, though, they're much higher risk and not tolerate kind of issues certainly related to transplant. So we're always happy to see these folks early on and discuss that with patients if necessary. And then, just to sort of briefly touch on alcohol-related disease, I think many of us are aware now that sort of old 6-month abstinent rule is kind of gone by the wayside. And that's really because when you look at large populations of patients with acute and chronic alcohol disease, the predictors of harmful drinking from a relapse perspective are not predictive of simply just that 6 months. It's really based on other factors, social support, commitment to it. So when we're seeing these patients and thinking about referring them for transplant, we always want to make sure patients are willing and able to engage in some sort of substance abuse resource. They need to have insight in their disease and willingness to accept treatment. We need to make sure that they have a plan or are willing to sort of control various psychiatric comorbidities which may drive that alcohol use, right? Depression, anxiety, and they definitely need good social support to help them through that process. If you're seeing a patient who's decompensated and has a MELD of 20 and at least is sort of willing to entertain this, I think we're always happy to see these patients and start that process to see if they would be a candidate. And the reason we do this for these patients is that actually, they have pretty good outcomes certainly in the short term, especially if they can stay away from harmful drinking patterns. This is a sort of a systematic analysis here in this chart, and you can kind of see the because it doesn't work here. But the 1-year patient survival, depending on this sort of study you look at, ranges anywhere from 77% in a French cohort to 97% in US cohorts, which is pretty impressive. The national average is about 93 to 94%. And the return to harmful drinking here, while yes, it's not zero, and we'd love that to be, it is only about 10%. And so you are probably saving more lives. And these patients often are younger, and so they may have more to give back to society and families. So with that, I'll conclude. I want to thank you all for this. This is where I work here at UVA, and as Dr. Hawk said, we do have an Arlington clinic one day a month here to kind of see patients for initial consultation for transplant. We also follow them pre and post transplant, so we kind of use it as an outreach clinic here to really kind of bring care closer to our patients. And just a final plug, I do have a cholestatic clinic as my clinical interest, and more than happy to see these patients as well. So appreciate it. Thank you.